We'll move on to our third case presented by our senior interventional cardiologist, Dr. Mohammed Alotaiby from Prince Sultan Cardiac Center in Riyadh. So,
hello, everybody. I am Dr. Mohammed Alotaiby from Riyadh, Saudi Arabia, Prince Sultan Cardiac Center. Thanks for Gulf Interventional Society for inviting me to present in their meeting. And I was asked to present a mitral valve. And here is my case. She's a 22-year-old female, single, medically free, apart from rheumatic heart disease, which was really diagnosed at young age when she was only 10 years. That's 2010, when she had mitral valve replacement tissue valve. And since then, she was ready to follow up and doing fine till 2018, when she was noticed on follow-up echocardiogram that her valve started to degenerate and produce mitral stenosis. 2019, she started to have symptoms, and her echo showed that the transthoracic echo and TE, here is the result of TE, showed ejection fraction 50%, hyperprosthetic degenerated mitral valve with severe mitral valve stenosis. The mean gradient was 12 in spite of a heart rate of 70. There is only mild mitral regurgitation, and her pulmonary artery pressure is normal. She was taken to the heart team discussion, and she was accepted for redo mitral valve surgery, and in fact she was scheduled for that. And I proposed, in spite of the unanimous decision of redo surgery, I proposed the idea of doing percutaneous mitral valve. And my justification was that she's still young and single, and there is a plan of life ahead of her, in particular of pregnancy and delivery, and there is no need for anticoagulation as yet because she was in sinus rhythm. And what encouraged me was the mitral valve prosthesis big 29. Initially, it was sort of where they went back to the patient, and the treating physician discussed it with the patient, and they liked the idea and brought it back to the heart team discussion. So she was discussed twice in the heart team discussion because probably of the off-label nature of the procedure, and the heart discussion, the heart team voted for percutaneous. And then we admitted her, and here is the procedure. This is the intra-procedure TE. And you can see here in this view that in the left of the screen, the degenerated mitral valve tissue prosthesis, clear signs of degeneration in 2D. And on the right side of the screen, it creates stenosis with mild MR. And this is the gradient, which is around, for me, gradient is 14, very severe mitral stenosis prosthesis. This is a 3D, intra-procedural 3D before doing the transseptal. It shows you the degeneration of the mitral tissue valve. So the procedure is done percutaneous, as you know, we go through the right femoral and we go transseptal, and you can use the TEE. I will show you later the fluoroscopic steps, but on TEE it's useful for all these steps of the procedure. So you go transseptal, and in the transseptal you go posterior because the mitral valve apparatus is quite posterior, but you need to go in something in the middle, not far away from the mitral to make it accessibility is easy. When you are inside, you can confirm passing through the prosthesis, particularly when there is a paravalvular leak. So you have to confirm that you are through the prosthesis itself. And when you pass it with the mitral prosthesis, the Edward prosthesis, you can even confirm, like in this picture, how much protrusion, where is the skirt, and how much should it protrude, which is usually 3 to 5 millimeter in the LA. So this is the picture when we captured when the prosthesis is across, and we are trying to make the ideal protrusion into the left atrium. This is shows after the deployment, and shows you the function of the new valve, the mitral valve, and the wire through. This is the 3D, which shows you again. You can use the 3D in both the diagnostic and in confirming all the procedure steps. This is after deploying the valve, but still the wire is across. And this is another view which shows you the functioning of the leaflet of the new valve is functioning very well, and the wire is across. And then this is when you through color, you will see that the mitral regurgitation is due to the wire, and you just confirm that. This is another view which shows you after removing the wire that the leaflets are thin, pliable of the new valve. There is no mitral regurgitation, and you measure the gradient, which was in this case was 3 millimeter mercury. Now this is the fluoroscopic part, and you see here that this is this degenerated surgical prosthesis, and we crossed transseptally. Sorry, we didn't record that the crossing through the septum, but that's through the septum, and we are dilating the septum. And after dilating, after the transseptal, we went through the valve. Usually we use Agilis to cross and with a Terumo wire, and then we pass either Judkin right or a pigtail through the valve, and over that we pass the coiled or brie-shaped wire, which is convenient in this case. Then we go with a balloon to dilate the septum, and we can use fluoroscopically plus the TE. And then usually if it is stenotic, you can test the valve like here, and you can inflate. I don't usually inflate the degenerated mitral valve, but except if it is really stenotic, and I test whether the prosthesis, the Edward prosthesis, will pass or no. In these cases, if it is too much degenerative or there are masses, it's ideal to put a cerebral protection device. Now, after that, we need you cross, and this is an important. You use the app to know, according to the surgical valve, where is the ideal position of the new Edward, and it's the usual. You introduce it in a similar way, and you prepare it in a similar way, except that you make the E sign points down so that the curve, when you curve it, it goes to the direction, to the right instead of the left. This is an important step here, which I capture and I wanted to discuss with you. If you notice, on the initial deployment, the sheath and the valve is here, the catheter is up here. Then I need to pull down, seeing the movement and the behavior of the valve as the second operator inflates slowly. And this is important to have a harmony between the two. The operator, number one, who holds the prosthesis and adjusts it, and this number two, who inflates according to the instruction. You see here, when we start inflation, we stopped inflation till I adjusted it. And this is important. So I have to pull for more than usual in this case, just to make sure that we got the prosthesis in the right place. Some people, they pace regularly, and usually I don't pace mitral valve and valve. I just do it without pacing, like in this case. So I think this is important. Then after that, you have to just confirm, in addition to the echo, TE, which is gives you a live picture. In addition, you do fluoroscopy, and you can just do panoramic view like here to see that the valve is well opened. And echo, you have to confirm the LVAT, that there is no acceleration, and the new prosthesis is functioning well. This is intra procedure. The gradient came down from 14 to 3 millimeter mercury, and this is again 3D after the deployment of the mitral valve and valve. Shows nicely thin leaflets and opening nicely. Now on this lady, we had follow-up on this January after a year of her procedure, and her mean gradient remained low at 4. There is no intrinsic or paravalvular leak, and she is asymptomatic and doing fine. This is the T transthoracic of follow-up. It's difficult to image, but you can see that the leaflets are well and thin and functioning well, and there is minute MR, and we usually check the iatrogenic atrial septal hole we made, and it's persistent in this case, but usually in all our cases, it doesn't have a sequelae. We didn't need to close any one of them. That's the confirmation of the current gradient, which is 4 only. Thank you very much for attention.
Great case, Dr. Alotaiby. As usual, I think it's a valve-in-valve become a routine or a procedure that's done in a cath lab nicely. You gain a lot of experience recently, and definitely we learn from you in this technique. So, Dr. Faisal, do you want to comment on?
Yes, Abu Abdurrahman always shows an elegant technique as usual. But my question to Abu Abdurrahman: do you care any more about the septal height? And do you routinely dilate with the Sabian? The nose cone is beautiful. Usually it crosses nicely. Do you have to pre-dilate in all cases? And really, this is also another demonstration of a hard team. In the previous days, before we have valve-in-valve, somebody like this would have gone for a mechanical valve and would have been followed up in a close anticoagulation clinic during pregnancy. But this opportunity of valve-in-valve gave her the chance to still have the chance to get pregnancy in the future without the anticoagulation. Great case, Farhan.
Thank you. To answer your questions, I don't usually pre-dilate. The commonest probably of our series, 50% of them are having mitral regurgitation combined with mitral stenosis, so I don't pre-dilate.
My apology, I meant for the septum, Abu Abdurrahman. Do you always pre-dilate the septum? Yes.
Yes, we have to. And the septum, yes, you have to pre-dilate, depends on the size of the prosthesis. If it's 29, I usually use 14 millimeter balloon. And an important point is not to pre-dilate like well before the process. You should make sure that you have liaised with your team that they are preparing the valve and they are ready, because the septum might recoil. So you should pre-dilate the septum just immediately before you just insert your prosthesis. And when you pre-dilate the septum, you stay for 30 seconds.
Do you care more about the septal height? Do you care about the height of the puncture, or you just do it same as you do for mitral commissurotomy?
It's more of commissurotomy rather than mitral valve, mitral clip. So it should be in the middle. You should target the middle, and it's a useful trick you can do is to go REO in the fluoroscopy, and you see the surgical prosthesis, and you just see the needle. The needle should be at the level or below prosthesis. Otherwise, if it is higher than the prosthesis, things will coil in the LA. It will be very difficult to recross. So your needle in REO should be at the level of surgical prosthesis or below it, so make it accessible.
Dr. Fadi?
Usually, I go inferior and posterior, like probably what Dr. Faisal wanted to say, because if you go very high, it's going to be very difficult sometimes to go across the LA, and you might lose the wire. And second tip is usually if the LV is extremely small, which sometimes you encounter, I usually externalize the wire through the aorta, so you don't end up losing. I had one case where I lost the wire, and with the Sapien, it's extremely difficult, and I had to cross back from the LVLA, snare the wire, and took me an extra half an hour. And one other thing is always make sure you look at the saturation at the end of the case, because sometimes you end up with some shunting, and you end up needing to close the ASD, especially with the 29. Sometimes you create a big hole in the septum, and you end up with hypoxia, and it's better to close it at the end of the case.
Anyone from other panelists and speakers have a quick comment? I have 1 minute.
Great case.
It's a great case. Whenever I do valve-in-valve, I call Dr. Alotaiby for instruction.
Okay, great. I think it's innovation can be in technology, but sometimes innovation can be in decision-making. You did a great job by doing or percutaneous to save her future pregnancy life till she have another operation.